Hi, my name is Shani Quevedo. I'm an internal medicine resident at HCA Florida Aventura Hospital. I will be presenting this case to you today, but not without the help of my colleagues, Dr. Arash Zaran, Dr. Leandro Long Rosario, Dr. Jose Rodriguez Castro, and our attending physician, Dr. Stephen Kaplan. The title of our case is Gastrointestinal Amyloidosis presenting as failure to thrive and syncope. Amyloid light chain amyloidosis is the most common form of amyloidosis and is the main type to involve the gastrointestinal tract. Monoclonal gammopathy of undetermined significance, also known as MGUS, is a plasma cell dyscrasia with potential to precipitate amyloidosis. Our patient presented with a constellation of signs and symptoms that led to his diagnosis. Our case is that of a 59-year-old man with a history of hemoglobin SC who presented with recurrent admissions to our hospital for new-onset orthostasis, weight loss, and dyspnea that was progressing over a 9-month period. Physical exam was unimpressive at first presentation. Labs were significant for a pro-BNP of 17,000. Echocardiogram and cardiac MRI showed a restrictive filling pattern with preserved ejection fraction. However, a specific etiology was not identified at that time. Serum immunofixation revealed monoclonal IgA light chain proliferation. Bone marrow biopsy confirmed MGUS. The patient later developed epigastric pain with associated chronic watery diarrhea, peripheral edema, and hypoalbuminemia. A CT of the abdomen demonstrated colonic wall thickening with trace abdominal ascites. Enteroscopy later revealed severe inflammation of the duodenum and jejunum that was characterized by edema, friability, scalloping, and diffuse petechiae. A colonoscopy showed similar findings, but with patchy involvement throughout. At that time, the histology was inconclusive. However, our suspicion remained high, so the slides were sent to a GI specialty lab. The pathology ultimately demonstrated immunoglobulin light chain lambda amyloidosis. He later developed a nephrosis as well. A workup for autoimmune, infectious, and malignant causes were negative, so the patient was ultimately transferred to a nearby hospital with specialty care services. AL amyloidosis develops as a result of monoclonal light chain deposition in various tissues. The cardiac and renal systems are most commonly involved. The main causes include PCDs and autoimmune illnesses. The diagnosis, however, is often delayed, so it should be suspected in a patient who presents with a restrictive cardiomyopathy or otherwise unexplained heart failure. In our case, our patient's illness manifested as a restrictive cardiomyopathy and likely protein-losing enteropathy. MGUS can precede amyloidosis by about 12 years, so this was an important finding in our case. Initial GI biopsies were inconclusive, but ultimately they cinched the diagnosis, highlighting the importance of remaining skeptical. Hi, my name is Shani Quevedo. I'm an internal